So our first speaker is going to be Mrs. Maisha Hutton. Maisha Hutton is the Executive Director of the Healthy Caribbean Coalition, the HCC, the only regional alliance of over 100 NCD-focused civil society organizations. Maisha holds a BSc in microbiology, an MSc in molecular biology, and a PGDip in international health. The HCC Secretariat, in collaboration with its civil society members, works with national, regional, and international public and private partners to drive NCD policy and programming in a number of priority areas, including civil society capacity building, cervical cancer prevention, alcohol policy, tobacco control, food policy, childhood obesity, and strengthening mechanisms for a whole of government and whole of society multi-sectorial responses to NCDs. So it's with great pleasure that I introduce Mrs. Maisha Hutton to you.
Thank you. So it's a pleasure to be here, and when I met Corinne at the UICC World Cancer Congress in Paris last year, and she was talking about the Sick Kids Initiative, and we got on to talking about curbing childhood obesity, she followed up after with a few weeks with an invitation for HCC to come and present, and it's an honor for us to be here. Before I go ahead, I wanted to acknowledge one of our directors in the room, and I'm not sure if he's in the room right now, but he was in earlier, and that's Dr. Homer Bloomfield. He's a member of our board of directors for the Healthy Caribbean Coalition, and Dr. Mortimer Moxie is a past director. I'd also like to acknowledge the Cancer Society of the Bahamas, again through Dr. Homer Bloomfield, and the reason for that is that HCC is in its essence an alliance of civil society organizations, and so it's important for us to acknowledge civil society in the room. In terms of the presentation today, I'm going to be focusing on curbing childhood obesity, and this is really through the lens of civil society, so definitely shifting gears for the past day and a half. And an outline of the presentation, I'll start with a bit more about the HCC, who we are, and you've heard a bit just now from the moderator. And then we'll talk about what the regional response has been and what civil society has done, and in particular what HCC is doing to contribute to this effort. And what do I hope that you all get out of this? I mean, normally I speak to civil society advocates and people who are, this is what they do every day. So as researchers and clinicians, I hope that you realize what the value is that civil society has, their contribution, what contribution they can make, and how important it is for you as researchers and clinicians to partner with civil society. And I was really heartened by the presentations we've seen where I've seen clinicians talking about their work in the community, working hand in hand with civil society organizations to affect change, whether that's at the community level or at the policy level, and really pushing for a policy and legislative reform to change the actual environment. So I have nothing to disclose. These are the CMU codes, and they'll come up at the end again. So I wanted to set the scene with this quote from Dr. Hennis, who is the director of the Department of NCDs and Mental Health at PAHO. And this is the first time in the history of humanity, 200,000 years, that our children will be fatter than their parents. This is a profound statement, and I would say that childhood obesity is in fact the canary in the coal mine. It really is a forewarning of a potential health catastrophe, especially in our region, and one that will affect entire generations. We have fragile, vulnerable economies, and we really cannot afford to not look this issue squarely in the face and address it with urgency. The HCC, as you've heard, we're an alliance of civil society organizations. We were really born out of the 2007 Port of Spain Declaration of Heads on NCDs, when they called for a whole of society response to NCDs, engaging civil society. We're a registered not-for-profit organization, and we're a rich network of over 120 health and non-health NGOs based throughout the Caribbean. This is a snapshot of what the organization looks like. Our president is Sir Trevor Hassel. Our patron is Sir George Elaine. We have a senior special advisor who is Dr. James Hospitalis of CARFA. We have an executive director, yours truly. A growing list of advisors across specialty areas, and then part-time assistants, and then our membership is across the bottom. At the heart of what we do is really supporting civil society to work with Caribbean governments to assist in the meeting of national, regional, and global targets, including those NCD targets embedded in the Sustainable Development Goals of the 2030 Agenda. What guides our work? We have a strategic plan which is developed in consultation with our membership, and it has 5 key pillars: advocating to national and regional policymakers to develop NCD policies; accountability, holding ourselves and our partners accountable to NCD commitments; building the capacity of civil society organizations so they are fit for purpose to not only provide services but also to contribute to advocacy for NCD policies; communicating the work of civil society organizations in the HCC membership pool at a regional and an international level; and building a rich network of civil society organizations that are speaking to one another and sharing their experiences and learning from one another. And sustainability is cross-cutting. Our project areas, we've heard them before, and this specific speech will be talking about childhood obesity. This is just a snapshot of the work that we do, our publications. It gives you an idea of the breadth of the topics that we cover. So obesity, and I'm not going to get into too much detail on the data because you've heard this over the past day and a half from Dr. Simeon as well as Professor Henry and others, but we know that obesity is largely preventable. We know that globally in 2015, the number of overweight children less than 5 years exceeded 42 million. This figure has doubled in 73 countries since 1980. And Professor Henry last night showed us in the Caribbean the trajectory is moving at a faster pace, with doubling within a time period of a decade. Antigua and Barbuda, Bahamas, Barbados, Belize. This data is from the 2016 Global Nutrition Report, and we saw this data already. Bahamas, I've highlighted, 69%. But this is 2 in 3 adults are overweight or obese. Childhood overweight and obesity. 1 in 3 Caribbean children overweight or obese, and this figure is growing. Less than a third of children in schools meet the recommended levels of physical activity. We know that obesity and overweight is linked to health problems in childhood, including mental health issues such as stigmatization and early onset of diabetes. We know it tracks into adulthood and increases the likelihood of developing NCDs. There are multiple drivers, and I won't get into them, but we know that they are biological, environmental, socioeconomic, cultural, and they are largely outside of the health sector. And at its core, childhood obesity is a social justice issue. We are all signatories in this region to the Convention on the Rights of the Child, and children have a basic right to health. So I want to share with you a lovely quote from the First Lady of Trinidad and Tobago, Her Excellency Rima Carmona, that she made last week at the UN General Assembly in New York. The HCC, in partnership with the permanent missions to the UN of Barbados and Jamaica, and with support of the other CARICOM missions, and as well as the Secretariat for the Pacific Community and the WHO, hosted a side event, which was really meant to bring high-level attention to this issue of childhood obesity in the Caribbean. And this is particularly important because we are leading up to the 3rd high-level meeting in 2018, next year, on NCDs. And if you all know the history of the high-level meetings on NCDs, you'll know that in 2011, the Caribbean was really the leader in energizing the global community around NCDs, and are still seen as leaders. So part of the aim of the side event was to try and re-energize that leadership, to get recommitment from the heads in this region around this issue in particular as part of the umbrella of issue of NCDs. So at the start of her comments, she talked about the hurricanes that have been affecting the region in the past month. And she said, as small island developing states, SIDS, we are already vulnerable to the effects of climate change and Mother Nature. In some part, Maria was unpreventable. However, to add NCDs and childhood obesity, which are for the most part preventable, to the challenges that we as SIDS already face, is irresponsible. And I thought that was a lovely quote. So what are we doing? What have we done in the region to respond to this issue? In terms of national policies, and again, this is a snapshot, not getting into too much detail, but fiscal policies, and here I'm really referring to taxation on sugary drinks, taxation on sugar-sweetened beverages. And 2 out of 20 of our CARICOM countries have implemented these policies. These are Barbados and Dominica. In terms of school policies, so getting these unhealthy foods out of schools. And I heard last night a resounding, yes, we can do that, from this energetic, youthful group. But so far, only 2 out of 20 of our countries have done this. Bermuda, and most recently Trinidad. Marketing regulation, mandatory front-of-pack nutrition labeling, 0 out of 20. There's some positives. Multiple countries have nutrition guidelines and policies, and there are many healthy school policies which include physical activity as well. There are 6 active national NCD commissions or equivalents, and the reason why I've included these is because these are potentially, and we've talked about, we know that there are challenges, and I say 6, there were originally 12, so there are issues with these national NCD commissions, but the global community is watching them because they are potentially powerful mechanisms for accelerating multi-sectoral action across government sectors, outside of health, including civil society and including the private sector. So it's important that we keep these on board and keep them connected. And I know you have a Healthy Bahamas Coalition, which we are also engaging with. And I've put a bullet at the bottom that there are plans to implement taxation on SSBs and school bans on SSBs in both Antigua and Barbuda and in Jamaica. And I wanted to mention just an interesting point about the Antigua and Barbuda tax. And this is just for those who were listening last night to Professor Henry's presentation. In most of the countries in the world, and indeed certainly in the Caribbean and Barbados and Dominica, there's no way to earmark the tax revenue because it goes into the consolidated fund. So they've been struggling with that challenge. But what Minister Joseph in Antigua has suggested, and they're working on this mechanism, is that they've identified the fruits and vegetables that are most popularly consumed by the public. And they have reduced the taxes on those, and they plan to increase the tax on sugar-sweetened beverages. So in the essence, it will be tax neutral. So we are waiting to see, I mean, Antigua's just gone through issues with Hurricane Irma, and they're rebuilding now and thinking, but we're waiting to see, hopefully within the next coming year, whether this tax is implemented and this approach is being used, because it's a potentially successful model which can be translated throughout the region. So what has been the civil society response, and what really is our role as civil society? Civil society has multiple roles. One of the major roles in the Caribbean is filling the service gap that the public sector cannot fill, and that's something that we do well. And then public education and outreach, and then one of the critical roles which we're kind of catching up on is that advocacy role and that watchdog role, pushing governments to implement policies and legislation and programs in some instances, and then checking them. Have you done this? Why haven't you done it? You committed to doing this. Why hasn't it happened? This is an example of various initiatives, either led by civil society in part or in partnership with other organizations across that gamut I've just described. So the first 3 are around physical activity, and they are all partnerships involving local ministries of education and health, as well as in some instances the private sector. The 4th is around school outreach to support healthy eating in school children, and this is happening. I mean, I've highlighted the Belize Cancer Society, St. Lucia, Dominica, Jamaica, but this is happening in NGOs across the region. And then the breastfeeding policy brief, this is something that we're working on with the breastfeeding organization in one of the countries to create an evidence-based for tailored advocacy towards governments aimed at generating policy in this area. So what is the HCC doing? We are trying to develop a framework for coordinated, integrated action amongst civil society across the region. And to this end, we've created the Civil Society Action Plan 2017 through 2021 for preventing childhood obesity in the Caribbean, using a life course approach from womb into adulthood and into and this was soft launched at the UNJEA meeting last week, and we will be officially launching it on World Obesity Day, which is October the 11th. The main frameworks that contributed to the design of this plan are global frameworks and regional frameworks. You'll see the ECHO report, which is the Commission on Ending Childhood Obesity from the WHO, also the PAHO Regional Plan of Action, the CARFA Plan for Healthy Weights, which contains their 6-point policy package, national childhood obesity plans, and then global and regional and national good practices in this area. And this is just to ensure that we are complementing what is happening, we are maximizing our impact, and that we are really working with governments and ensuring that there is alignment across priorities. So within our plan, we have 7 priority areas. The first is trade and fiscal policies. The second is nutritional literacy. The third is early childhood nutrition. 4th, marketing of healthy and unhealthy foods and beverages for children. Then we go on to school and community-based interventions. Resource mobilization, because we know that NGOs often face this challenge around where do they identify resources to do the work that they do. And finally, strategic planning, monitoring, and evaluation, because we don't know where to go if we don't know where we are. So what is the goal? The goal is by 2025 to halt the increase in childhood obesity in the Caribbean, and this really mirrors the international goals around obesity and diabetes, not really to reverse it because that's a bit ambitious. So right now the aim is just really to halt it, and this is in support of the Global Action Plan and their 2025 targets. What's the purpose? And I've underlined here, contribute to the development of implementation of relevant policies, legislation, and regulation, because we want to be clear that our endpoint is around changing the environment, changing the structural environment so there is population level change. We're not concerned with little bits of programs, which are interventions. We're concerned with, at the end line, governments changing policy and legislation. And the overall outcome is really a strengthened civil society community that can effectively do this at all levels, whether they are focused on outreach and education to create social movements where people are demanding change because of the information they've provided, or they're actually talking to policymakers about the specific policies that they can enact. This is a snapshot of the plan. We just talked about those priority areas, and we've got some key policy asks because we are trying to be smart and we're trying to prioritize what we're focusing on. And so I'm going to go through each of those with you now. Under the first area, we're going to focus on taxation of unhealthy foods. And how are we doing this? Throughout all of these key asks, we're looking at building public awareness. So providing information tools so that we can build awareness amongst the public so the public is informed and they can call for the change that they need for healthy environments. Developing policy briefs. This is a policy brief that we put together around the taxation of the sugar-sweetened beverages in Barbados, a closer look at that policy so that civil society could really better understand the policy process. What's the actual policy process and where are the entry points for our advocacy? And then designing and implementing a regional advocacy campaign to drive policy and legislation. You all would have seen this last night if you were there to see Professor Henry's presentation. This is some work that we did emerging out of the UK Action on Sugar, where they looked at the popular international drinks and the sugar levels, and they contrasted those with the WHO maximum amounts of sugar consumption per day. For children, that's 25 grams, for adults, 50 grams. And so we wanted to see whether or not our drinks and whether or not Coca-Cola manufactured in the region was any higher in sugar content than Coca-Cola manufactured in Canada. And we found, in fact, there was no difference. But more important is the fact that for each of those drinks, you'll see, with the exception of one on the bottom in the UK, that they all exceed the daily maximum recommendation by WHO. That's the maximum for children, and they approach the maximum for adults. Sure.
This chart, I'm not quite fully understanding.
Sure. So the daily maximum recommended intake for sugar for children, that's the first, this line here, is 25 grams. And for adults, 50 grams. So what we did was we found out how much sugar was in the serving size of these popular drinks, whether it was manufactured in Barbados, Belize, Jamaica. We recognize their volume companies which manufacture in one country and distribute throughout the region. And the primary goal of this initiative at the outset was to demonstrate that in some countries, for example in Mexico when they did this many years ago, they found that the sugar was off the charts compared to the same bottle of Coca-Cola that was manufactured in New Jersey. But we found there was no difference, but the fact was that the numbers were still quite high. Where we did find...
So different countries add different amount of sugar?
Yeah, different countries have different, yes.
Sprite, Pepsi.
Yeah, there's different recipes, let's say, in different countries. And oh yeah, and you can see that with cereals as well. Yeah, and what the manufacturers will say is that our certain target audience prefers more sugar. Where we did find alarming data was when we worked in country and we looked at the endemic drinks, the local drinks that our countries are manufacturing. And we got our civil society organizations to go into the supermarkets and simply just take a photo of the product packaging. And so I've just taken Suriname out, for example, but we did Suriname, Barbados, Jamaica, Belize. And if you see, first of all, for 25 grams, most of them exceed for children. And when you look at these two top drinks across the top, I mean, that's maximum for an adult, and they've gone way over. The graph for Barbados, most of the drinks, the graph for Barbados, most of the drinks exceed the adult's daily allowance. And these are, I don't know if you get the little Tetra Packs here. These are these small little drinks that kids take for lunch, and sometimes they'll take 2 or 3, and that's it. So they've exceeded it. And when I showed this to mothers in my office, I mean, they were shocked. So this is the kind of information that we as civil society organizations need to be disseminating to the public, so they are armed with the information to make decisions about not only the food that they consume, but what they pressure their policymakers to do in terms of legislation. So the next area is mandatory front-of-pack nutrition labeling. So what we're doing again is public awareness and nutrition literacy. We had an MPH student work with us over the summer, and she went into supermarkets, and she looked at the content again of sugar of various cereals, and again found that our sugar content was higher. This time it was higher than the other brands. But what she also did was she undertook an assessment of consumer attitudes towards different labels. And you guys have all seen kind of the traffic light label with the red, the amber, and the green. Has anyone seen the chili labels? They're like a black hexagon, a black pentagon. So Chile has just now introduced these new labels, and in the public health community, these are being regarded as very, kind of the best new label that's out. And basically what it does is it says to you, if it's a black pentagon, basically this is not good. This has exceeded all of the different, this has exceeded the minimums for sugar, fat. And so as a parent, if I see this black pentagon, I know that this is a no-go. And the reason why the Chilean, and I should have probably got a picture of it, but you can email me if you want it. The reason why it's better than the traffic light is because in drinks like Coca-Cola and a lot of these soft drinks, they're all getting green. They're getting green all the way across, good to go, because they really just have, except with the sugar. So everything else is green, and then the sugar is red, right? So they're not really giving a good indication of the fact that this is not something that you should be purchasing. Whereas the Chilean approach is much more informative. So, and then advocacy to get these done. So the other area we're working in is legislation related to the International Code of Marketing of Breast Milk Substitutes. And this is a really important area because the trajectory towards obesity starts in the womb. And we want to encourage mothers to eat healthy when they're in the womb and then to breastfeed as much as possible, at least to 6 months. So we're working with an organization, as I mentioned earlier, around an evidence brief for advocacy, looking at what are the specific policies we can promote. One of those is allowing women to breastfeed in the workplace in safe spaces, allowing for longer paid maternity leave. I mean, and that is critical. As a mother who has had to breastfeed, you don't really want to be going back to work after six weeks because you can't breastfeed then. It just makes it a lot more difficult. So looking at policies in that area and really trying to push change. And then supporting the Baby-Friendly Hospital Initiative, which is also very important because healthcare providers are often the ones that push mothers when they've just had babies to go to the bottle rather than to breastfeed. Can I ask you a question? Would you mind holding your question?
Can we save the questions till the end, please?
Thanks. Banning the marketing of unhealthy foods and beverages to children. Now, I've used Cool Kids Fruta here, but this is by no means an indictment of that one brand. There are multiple brands. We can go to the supermarket and see tons of marketing to different children about these unhealthy products. These were one of the products that we found had in excess of the 50 grams of sugar per day for adults, not even children. So again, public awareness. We're about to start working with VII in Barbados to do a pilot project where we're mapping the exposure of marketing to children and adolescents in and around schools. And this is a really exciting project because we're working with a global expert through PAHO, so it's a really unique opportunity for us to capture quantitative data on the amount of advertising that children are exposed to in school settings and in and around school settings. And at home as well, because they'll be monitoring TV and radio. And then banning the sale and marketing of unhealthy foods in schools. This is going to be one of our flagship initiatives because we really believe that these foods need to come out of schools and out of the perimeter of schools, these foods and beverages. So public awareness, we're also working on a regional advocacy campaign with PAHO, and the mapping of the marketing exposure is part of this. And then mandatory physical activity in schools, public awareness again, and advocacy. I put this picture of a child with an iPad because we know that these screens are contributing in a massive way to the increase in sedentary lifestyles of these children. Obviously, school policies are the fact that PE is no longer mandatory, the fact that children are required to study for an 11+ exam, and they have no time for PE, and then CXCs, and then CAPE, and so on and so forth. This is a massive issue that we need to deal with. One of the really, I guess it's close to my heart, we have the element of this Childhood Obesity Action Plan is that we have something called our Childhood Obesity Prevention Scorecard. We call it COPS. And the point of this is really, it provides a tool for civil society organizations to map the local policy environment so they can tailor their advocacy actions to respond to priority gaps. So really it's about doing what many of you have said you've done. You're engaging civil society in the research process. We're engaging civil society in the surveillance process. If they understand where the gaps are, they can respond better to the gaps. They know the environment. Rather than telling them, you should advocate for this, they will know that, hey, I don't have a school ban here, but I have a nutrition policy or nutrition guidelines. I can build on this. So it's a very simple scorecard. It allows them to say yes or no, we have this policy or intervention in country. Whether it's partially, fully, or not at all implemented. Who are the implementing agencies, so they know who the stakeholders are they need to work with, and then a link to the actual policy document. And this will be posted online on the HCC website in about a month, which will allow not only civil society to check the plan and to feed into it, but it will allow governments to look on our website and ensure that the data on there is correct. And it will motivate them when they see that one government has done something and they haven't, to maybe perhaps accelerate action in that area. So who are our implementation partners? Civil society organizations. The Cancer Society of the Bahamas is one of our partners on an upcoming grant. PAHO, they're working with us on the advocacy piece, mapping the marketing and labeling work as well, and that's through a regional partnership, the labeling piece with Chile, to work with them, and there's been an exchange of professionals to really see how they did it over there, how civil society did it, what were the partnerships between government and private sector, and how they implemented both the marketing legislation and the labeling. The Bloomberg Foundation, have you all heard of Bloomberg Foundation? Yes? Well, you've heard of Mike Bloomberg, right? Yeah? So he's invested significant amounts of money across the globe in tobacco control, and obesity prevention is something that they've just started working in. And they've done a tremendous amount of work in Mexico with their sugar-sweetened beverage taxation, and in South Africa. And they have just recently committed to providing funding for Jamaica and Barbados to do the very same thing around advocacy at the grassroots level led by civil society to trigger policy change in the space of obesity prevention. So they are also important partners. The first time ever, the Caribbean Development Bank has funded a civil society organization, the HCC, and they funded us to build the capacity of civil society organizations to respond to childhood obesity. And the Cancer Society of the Bahamas is one of the 5 organizations that is going to be a beneficiary of this grant. CARFA, in implementation of their 6-point policy package. Academia with us are strong partners. We've just signed an MOU, HCC has, with the UE Open Campus to facilitate education to all of their students and to education and open campus education throughout the region. We're also working with CARE and other academic institutions to facilitate and to partner on research and to educate the community. And we'll also be working with governments, ministries of health, and ministries outside of health, those listed there, as well as national NC commissions. And the point of this is really to ensure policy coherence. So policy implementation and then coherence across the sectors. And then private sector, reformulation, healthy workplaces or workplace wellness programs, and advocacy. And I've highlighted Sagicor there for the next slide. So in terms of the private sector contribution, I'm going to just give you a snapshot here because there's not a whole lot to talk about. There's been resistance, there's been reformulation, and there have been partnerships. So in terms of resistance, the first little headline I've got there is Bajans prefer extra sweet drinks, and that's why we're not going to reformulate. You know, if you give my child something really sweet and I give it to him every day, he's going to want that same sweet drink every single day. He's not going to say he wants something with less sugar in it. So that's an excuse that the industry uses quite often. They also use the excuse that the taxation is regressive. In other words, it's going to hurt the poor the most. But data has shown that the poorest of the poor benefit the most from these taxes because they are the one who consume most these unhealthy products. There's been reformulation. Some manufacturers have committed to reformulating, but there needs to be, in those settings, there need to be laboratories to verify that the drinks have actually lowered their sugar. And there's been partnerships. The National Food Industry Task Force in Jamaica is a Ministry of Health instrument which has private sector on board. So again, the kind of world is watching this because this is the first time that private sector is actually in a position to influence policy, which is a general no-no in public health. So we'll see how this works because it could be a potentially good model. And then peer accountability. This is a really lovely example to the right of private sector playing their role. Sagicor sits on the National NCD Commission in Barbados, and the past few months they've taken to holding their private sector counterparts to account. They've called for the halting of marketing of unhealthy foods from their counterparts in the manufacturing sector. So a really good example of private sector saying to their peers, this action needs to change. And then we need to learn from global experiences led by civil society. And I've given a few examples there. What I just want you to take away from this slide is that the background photo is from the campaign in Mexico led by a group called El Poder, a very powerful, influential civil society organization. And they put these billboards all over the country. And it was an aggressive campaign where they would have, you know, skeletons in the middle of public areas talking about how sugar was killing the country, really using data to scare and incite public rage around this issue and then push for policy, and they were successful. So in terms of next steps from us, continue to build capacity of civil society organization as we implement this action plan, design actions based on regional and global evidence, implement these actions through partnerships, and partnerships are critical. We can't do it on our own. Create these social movements that really advocate for change and then ultimately influence policy and programming across all sectors. And then hopefully we will modify the environment with that policy change and support changing behaviors, ultimately leading to a halt in the rise in obesity. So my last slide, I want to leave you with a closing comment from our patron, Sir George Elaine. The increasing prevalence of childhood obesity in our places and in our time is an affront to all of us. Yes, it is a public health issue, but it is especially pernicious because it represents a flagrant negation of the rights of the powerless and the voiceless, rights to which the world has subscribed. It is past time for individuals and agencies to be outraged. Thank you.
Thank you very much, Mrs. Hutton. Do we have any questions, Mrs. Hutton? There's one at the back. Let me pass the microphone.
Very good presentation. Thank you for that.
Thank you.
I have a quick comment. I agree with you that there is an epidemic and a problem with childhood obesity. What I don't agree with is I don't think that the kids are going to be bigger than the parents, because a lot of the parents are huge. So I mean, I think the problem is obesity on the whole. Now, there was a slide that you had put up earlier in the presentation in terms of what can potentially be done. And you had alluded to one of the potential solutions was taxation of unhealthy foods. My question is really in relation to that, because I think part of the obesity problem has to do with poverty. And I myself try to eat healthy, and that tends to be very expensive. I tried to be vegetarian for a while. I got to quit that, couldn't afford it. But I think the issue is that a lot of people eat unhealthy, not because they really want to eat unhealthy, but you really can't afford to eat healthier. So as opposed to taxing unhealthy food, because this may come to the issue as to if you're going to eat or not, What about removing taxation of healthy food as an incentive to get people to eat healthy? I know for us, we have VII, so maybe I guess in this region, it could be that maybe fruits and vegetables are VAT-free.
Right, so that's probably why I mentioned the Antigua example. In all of the work that we do, and I guess there's so much to cover here, so I could have gone into so much. And if you saw Professor Henry's presentation last night, you'll see that they did research to show that it was exactly as we thought. It was more expensive to eat healthy than to eat unhealthy, and we all know that. And so part of the WHO recommendations are not only to tax unhealthy foods, but to provide subsidies on healthy foods. So the healthy option is the affordable option. And so when we advocate for, when we as advocates, and you'll see in our plan, advocate for taxation, there is also an advocacy piece to advocate for subsidies on healthier foods, to put healthy foods into the VAT-free basket. Those types of initiatives are very important. And similarly, provide options. When we're talking about taking sugar-sweetened beverages out of schools, you need to make sure that clean water is accessible. We've been in countries where they say that some of the schools don't have access to clean water. So if you take juices out, there's nothing for children to drink. So we need to make sure that when we're calling for these actions, we're smart about it, and we're also providing options for people which are realistic and achievable.
We're going to have one last question from Dr. Lochan, and then we're going to move on.
Okay, I must commend you guys on the policies and approach, but I think for a radical change, we need radical action.
Yeah.
We live in a time and a world where we want to be. When I was a child, we walked to school, we rode our bicycles to school. After school, we were in the playground playing and running. Now we jump in a car and we come home and stay indoors. When you needed something to eat, you went outside, you picked a guava or a mango or something. We don't plant fruits anymore in our yards. And now when you're coming home from school, you stop at Wendy's and McDonald's. Unless we tax or we stop every corner there's a McDonald's or a fast food place, I don't see us policies making a change unless we can stop these businesses or tax them to such a point where it's so expensive we can't afford it. And then we need to go back to being physically active in urban planning. We need to put a community park every 2 corners. The children can go out there and run and play and be safe too.
It's a very complex issue. I mean, and there are many drivers, and we talk about you'd have to build sidewalks so that kids can walk to school. Right now in Barbados, nobody can really walk to school. It's just not safe. And that's similar across the island. So there are many complex issues.
Thank you very much, Mrs. Hutton. And our first resident is going to be Dr. LaShanne McKenzie. Her paper is on epidemiology of congenital cardiac anomalies at the Princess Margaret Hospital, Nassau, Bahamas, from 2009 to 2016.
The most obvious question is, why should congenital cardiac anomalies, abbreviated CCA, be studied in the Bahamas? These anomalies have been defined by Syested et al. In 2012 as abnormalities in the cardiocirculatory structure as well as the function that are present from the time of birth. They have been seen across all geographic regions and have spanned the times. Consequent to CCA have been infant deaths, reduced quality of life, and ultimately significant economic strain for countries. The thought is that by determining the distribution, incidence, the type of anomalies present, as well as some of the risk factors and associations, we can implement preventative strategies, appropriate screening, effective treatment, and we can get some greater insight into directed management. With a retrospective cohort of over 1 million children, Schuler et al. Determined that there was an upward trend in the incidence of CCA from the year 2003. Likewise, with the use of a meta-analysis, Van der Leend et al. Determined the same thing. And from their study, they were able to determine that there were about 8 cases per 1,000 live births globally. In 1993, work by Sorboni et al. In Guadeloupe showed that the incidence seen in this developing country was about 6 cases per 1,000 live births. And the types of anomalies they saw most commonly were first ventricular septal defects, atrial septal defects, patent ductus arteriosus, and in 2010, in the Czech Republic, CPEC showed the same thing. They also noted that tetralogy of Fallot was the most common cyanotic congenital lesion seen. At the time of this research, the only study in the Caribbean was done by Sorboni et al., and that was from 1993. And at that point, there was no data from the English-speaking region. Now, from the Bahamas, we only have anecdotal data concerning the epidemiology of CCA. So there remained a void in the literature at this point. And given what we have determined from our literature review, it's imperative that countries such as the Bahamas are better able to reduce the impact of CCA on its population. The aim of this study was to describe the distribution and the determinants of CCA at PMH during the study period. Some of the objectives that were noted was to determine the socio-demographic profile, the frequency of occurrence of CCA, describing some of the types of CCA that we had diagnosed, and to get an idea about the associations as well as the magnitude of these associations. It was hypothesized that, according to the literature review, we would have seen septal defects most commonly, followed by PDA and pulmonary stenosis. We also postulated that rare CCA would be seen more commonly compared to the literature. And based on what we noted, we predicted that there would be about 6 cases per 1,000 live births. Sorry, my slides are just moving. Prior to beginning research, ethics committee approval was obtained, and what was done is that we went through the pediatric cardiology logbook, the echocardiogram, as well as the clinic logbook, and that gave us the patients that we could identify to be a part of the study. The autopsy logbooks were also accessed to include those patients who were only diagnosed by postmortem. To be included in the study, patients had to have been born in the Bahamas between the study period, had to have been patients at PMH, and had a diagnosis of CCA. They were excluded if they did not meet the above criteria, as well as if there was a premature patient who had a diagnosis of PDA, as this is not considered a true congenital cardiac anomaly. In terms of the statistics used for this study, we use descriptive as well as inferential statistics, descriptive with the use of means, medians, modes, and other percentages, and inferential Pearson's, Kramer's, and type 1 error. And this gave us some more information about the population parameters. So the first figure is a pie chart of the race of the study participants. And as clearly seen, the majority of participants were Black. The other figure shows the maternal nationality of the study participants, and contrary to what may have originally been thought, the majority of the patients' mothers were in fact Bahamian, and they originated from 4 islands: New Providence, Grand Bahama, Abaco, and then Eleuthera. And this is not surprising because Bahamian statistics show that New Providence is the most densely populated island, followed by Grand Bahama and Abaco. The first line graph that is shaded in black illustrates the number of CCA diagnosed per study year. And from the graph, you can see that from 2011, the incidence of CCA was actually rising. And in fact, in 2015 alone, there were 71 cases. For 2016, the study only included the first 7 months of the year, and we had already 55 cases, and that surpassed all the totals from 2009 to 2012. The other line graph on, sorry, that shaded blue shows the CCA incidence proportion per 1,000 live, and that's from the years 2009 to 2014. Unfortunately, at the time of the study, the live birth statistics were not available for 2015, and 16 was not complete, so we don't have the data for those. However, it's noted that our incidence has been climbing, and in fact, the average between 2012 and 2014 was 12.15 cases per 1,000 live births, and this number exceeds all of the results that we found in the literature. And strikingly, if we use the benchmark study in Guadeloupe, our incidence actually doubled that seen in Guadeloupe. So that's the only real country we have for comparative data in terms of a developing nation. This table gives us the number and percentages of CCA identified in our study population. So unlike what we noticed in the literature, pulmonary stenosis or dysplastic pulmonary valve were the most common CCA seen in our population. And this was followed by atrial septal defect and PDA. And in keeping with the literature, tetralogy of Fallot was in fact the most common cyanotic lesion seen. But what we did note was that over the study period, we had 3 cases each of hypoplastic left and right heart syndrome. Now, in no study in the developing world were these anywhere near the top 3, but in our study, we had 6 in our short time frame. The study in Guadeloupe, interestingly though, showed 5.7% of their cases were this particular rare finding, hypoplastic left heart syndrome. So the implications of this are far-reaching because these conditions require early surgical intervention, they have significant morbidity as well as mortality, and moreover, they cannot be corrected in the Bahamas. So we need to take this into consideration. This table highlights maternal illness in the study participants. Most of the mothers had no illnesses, in fact, but unfortunately, up to 21.5% of the data was missing or not even documented. But nonetheless, from what we did find out, most of the mothers had hypertensive disorders, whether pre-gestational or gestational. So this is in keeping with the theme today in terms of obesity and weight challenges, as these illnesses in particular are related to obesity. This was followed by diabetes shortly thereafter. Now, what we found in the literature was that diabetes was closely and strongly associated with the development of congenital cardiac anomalies. However, from the study, it was seen that pre-gestational hypertension showed more of a link with congenital anomalies, and in particular with PDA. And in fact, there was a 234% increase in the likelihood of PDA in the presence of maternal pre-gestational hypertension. This was also seen with trisomy 21 in that there was an increase in likelihood of 335% if the patient had trisomy 21 as well. So in conclusion, the occurrence of congenital cardiac anomalies was double that predicted. Unlike what we thought from the literature, pulmonary stenosis and dysplastic pulmonary valve was the most common acyanotic congenital cardiac anomaly. In keeping with the literature, tetralogy of Fallot was the most common cyanotic anomaly. Furthermore, it was seen that rare anomalies were more common in our population, such as hypoplastic left and right heart syndrome. And additionally, one of the associations seen was that pre-gestational hypertension as well as trisomy 21 are significantly associated with patent ductus arteriosus.
So wonderful research, but I need to ask you, is there any family history in these patients?
Okay, so we had a lot of difficulty in terms of documentation. However, from what we did discover, family history was actually not significant.
I asked that because 70% of our babies are born out of wedlock. Now, those babies very often carry their mom's surname, so they don't have their daddy's surname. So some of these patients could be having babies for their siblings. And that can surely contribute to the high amount of abnormalities, not just heart, that we see in this country.
Yeah, so one of the recommendations that we had was that we need more standardization of data collection and record keeping, because it was very hard to find out paternal information. We tried to get ideas about socioeconomic status, because the literature showed that that had a correlation to congenital cardiac anomalies, but it was very difficult to obtain that data.
My question, sorry, LaShawn, Dr. McKenzie, congratulations, you just graduated with your DM. So I want to congratulate you. And the question was, you mentioned that there was some limitation to your study, that you didn't get all the data, and hence that may represent why the immigrant population was not representative in your study. I would suggest that if we did a retrospective study before 2009 and compare it with your study now, you may see a change and difference in the number of CCA. What do you think about that?
Well, what the information that we did actually have, the information we did actually have was the maternal nationality, so that aspect of the data we had all the information for. So it is actually true that most of the mothers of children with CCA are actually Bahamian. So I honestly don't think that a prospective study or a study with further years would change that parameter, because it was overwhelmingly Bahamian mothers.
Those children now are age 9, 10, or younger. Maybe we can do a study in that age group, 8-year-olds with CCA, and that may show a difference. That's my 5 cents.
Thank you. Thanks.
Thank you very much, Dr. McKenzie. And now we're going to move on with Dr. Ianthe Cartwright-Bastian's presentation, A Descriptive Epidemiology of Pediatric Deaths, 1 to 17-year-olds at Princess Margaret Hospital, Nassau, Bahamas, a retrospective chart review.
Good afternoon. So I'll be presenting a descriptive epidemiology of pediatric deaths for children aged 1 to 17 years old, studied here at the Princess Margaret Hospital, Nassau, Bahamas, and it's a retrospective chart review. The other authors and persons that helped out in my presentation are noted above. I do not have anything to disclose, and this is the CME code. I will come back to this at the end of my presentation. So we know that children represent the future of the nation, and we all expect that once children are born, we want them to grow and mature into positive adults. When they die, we seek to find out what was the cause of their death. It affects the parents, it affects the community, and it affects the physicians involved. I put this picture up there to show that in 2001, Millennium Developmental Goals were created, 8 of them, by developing and developed countries to come up with how we could reduce childhood mortality, and that was the MDG 4 goal that was established. The Bahamas was a part of this. So in doing my study, we realized that the Bahamas infant mortality rate in 2012, as documented on Commonwealth Health Online, there were 14 deaths per 1,000 live births. The under 5 mortality rate was 17 deaths per 1,000 live births for that same year. Our Millennium Developmental Goal that we proposed was to reduce our under 5 mortality rate to 8 deaths per 1,000 live births. We needed to figure out how we could achieve this. In review with the WHO guidelines, we noticed that the top causes of death under 5 overall in 2010 were pneumonia, congenital anomalies, and prematurity. And the top causes of death in adolescents was road injury, HIV/AIDS, suicide and violence, and lower respiratory tract infections. As would be expected, though, in 2012, the WHO clearly commented that adolescent deaths were really, really low, and this is good. So why do we want to do this study? There's significant concern in the Bahamas about the cause of death for infants, children, and adolescents. And we know that most are preventable. but we needed to address our MDG4 goals and foster a steady decline in our childhood mortality rate. The Bahamas had seen an improvement in childhood mortality rate over the past decade, and we had a local publication in our basic health indicators in 2013 that showed this, that we had a reduction in infant mortality from 21 to 16 deaths per 1,000 live births from 2009 to 2011, respectively, and childhood mortality from 23.2 to 19.2 deaths per 1,000 live births for that same time frame. So we sought out to focus on under 5 years old. We noticed that in our research, most of the studies focused on the under 5 years old, and the health status of the older child was not clearly evaluated. So we sought to seek out that. Our aim was to preliminarily explore the descriptive epidemiology of pediatric deaths in children aged 1 to 17 years at the Princess Margaret Hospital over this 6-year period from 2010 to 2015. We wanted to determine the mortality rates for the ages 1 to 4 years and 5 to 17 years old in that time frame, and also to determine what was the causes of death associated with these age-related subcategories. We hypothesized that the mortality rate for the 1 to 4 years old would be about 6 to 8 deaths per 1,000 population for each of those years studied, and the leading causes of death we thought would be infectious causes and congenital anomalies. For the 5 to 17-year-olds, we thought that it would be about 2 deaths per 1,000 population for each year, with the leading cause of death being accidental injury, HIV, and AIDS-related causes. So we started with a retrospective chart review. Consent was obtained to retrieve and evaluate records from PMH. We also gathered information from the Health Information and Research Unit at the Ministry of Health, the Statistics Unit here at Public Hospitals Authority, and the Births and Deaths Release of Information Unit of the Medical Records Department here at PMH. We compiled and correlated all of this information to ensure accuracy and to ensure that there was no overlap of all of the data that we had received. We wanted to include all records of children that were available who were 1 to 17 years old, who either died at Princess Margaret Hospital or presented to this institution at the time of their death. We did not want to include those who were less than 1 year old and those who died in the Bahamas but were not seen at PMH. So what were the results? We found that there were 178 total deaths for the 6-year time frame for this age group. 15 of those deaths, though, we had no information for in the system. 11, we had absolutely no information that we could extrapolate. But for 4 of them, we were able to extrapolate the data from all of the resources that we had. We found that 3 out of the 4 children were between 1 to 4 years old, and 1 of those children were 8 years old. Of the 178 children that died, 60% of them were males, and about 40% were females, and the median age of death was noted to be about 6 years old. If you notice on the graph, over the course of the years, there was a male predominance for all of the years included, except for 2011. For the 1 to 4 years old, we calculated a death rate of 5.4 deaths per 1,000 children of that population. For the 5 to 17 years old, we calculated 2.1 deaths per 1,000 children of that population, and the overall death rate was 2.6 deaths per 1,000 children in the population. And this is a graph that depicts that. We notice that there has been, which I projected already, a steady decline in the death rate over the time frame. However, we do note for the 1 to 4 years old, from 2014 to 2015, there seemed to be a little increase. But the overall death proportion, which is elicited with the blue line, it shows that overall our death rate or child mortality rate for that age group seems to be on the decline. 8 categories of death were highlighted. Sorry. And if you look, you notice that overall, the highest rate was with accidents, including drowning and violence, for the 1 to 17 years old, as noted over that time frame, and that contributed to about 30%. The second was pneumonia or infectious causes, which contributed to about 22% overall. When we looked at it related to the 2 age groups, for the 1 to 4 years old, it was pneumonia, as the most predominant cause. And for the 5 to 17 years old, the most common cause was accidents and violence, including drowning. So overall, we noted that the median age of death, as I said, was 6 years old. There was a male predominance noted over the time frame, but there were no other studies that evaluated these age groups that we elicited in our study. So it was difficult to compare the information because most studies, like I said, considered the under 5 age group. So the child death rate has shown a steady decline over the period. There has been steady progress towards achieving the MDG4 goals, which ended in 2015. However, the Bahamas did not achieve it. Yet, the MDG4 goal overall for the world was achieved. So we are now on Sustainable Goals 3, and the Bahamas is a part of that in ensuring that the healthy lifestyles of children and promoting the well-being of all kids are continued. And so we will continue to enforce a steady decline in our childhood mortality. Why did we see this decline in childhood mortality? We think that there was an overall improvement in the Bahamas' health care as a result of ongoing public education and educated resources geared towards upgrading access and delivery of health services over that time frame. We could not highlight any implementation or any service that was implemented at that time that was specifically geared towards the MDG4 goal, but we do know that a lot of stuff has been done in our society in ensuring that we have provided better primary care. So the leading cause of death under 5 generally is pneumonia, and this was similar to the 1 to 4 age group, which we got as pneumonia as our most common cause. Closer evaluation of the 5 to 17-year age group, where we highlighted that accidents and injuries was the most common cause. In looking at it more specifically, we noted that most of those injuries were actually due to road traffic accidents, with 37%. That followed with drowning as our second most common cause under accidents and violence. So in conclusion, most of the deaths that we noted were due to preventable causes. We wanted to implement, or we think it should be implemented, a childhood mortality review committee that would evaluate these preventable causes and seek to institute some type of policies or ensure laws are enforced to ensure that preventable injuries and accidents can be avoided. Public service announcements can also be created to educate the public and children at large on what can be avoided. These are my references. Thank you.
Thank you very much. Are there any questions?
Thank you, Dr. Cartwright.
Hi.
Hi, Ante. Cartwright. Thank you. Congratulations. You're one of the new DMs in pediatrics. I want to congratulate you on that. But let's get back to your presentation. Did you look at the BIDs, the cause of death in BIDs? For those who don't know, that stands for brought in dead. And we do have a significant number of those. What did you study them? Sorry.
So in evaluating the notes, the medical records that were available, first there's a limitation in obtaining records. Secondly, with the brought in deads, it's sometimes difficult for the age group for the information to be elicited. So in reviewing the records, a lot of them just said brought in dead. And in my brief consultation with the consultant pathologist, it depends on what it is that we might get a specific cause of death. So we really heavily rely on what the ER officer may document at time of presentation or the storyline that comes in. But most of the notes that I reviewed that were brought in dead pretty much just said that, and it was general.
But most of those are severe chronic illnesses, and there's a mandatory requirement that those brought in dead,
Yes, they were
they
highlighted
should have
as
an
coroners.
autopsy.
They were highlighted as coroner's cases, and so their autopsy was done. But even in speaking with the pathologist related to that, sometimes it's still difficult unless there's a storyline prior to determine the cause of death that is just present at that point in time. But they were highlighted as coroner's cases, and it was done. But that would reflect why most of our injuries were noted to be accidents.
Quick question. I may have missed this. Do you have death certificates or? Are there death certificates available? Is that
Yes.
useful?
So we reviewed the death certificates that we could find that were attached to notes. The problem, though, is that a lot of the death certificates, when reviewing with the death and release unit, they are not filed separately for children, one, and two, they're not filed for year. So you have to go through the alphabetical order and seek. So what I had to do with the health and the death and release unit was they had recently started their own spreadsheet, and we tried to extrapolate information from what they had, the information that I had gotten from the Health Information and Resource Unit and the Ministry of Health, which I had to decode because they had already had that in IC decoding, to then extrapolate what I got from PHA and put it all together to see, is the child the same child? And also note that on the death certificate, it may be their government's name, but in hospital, it's whatever name you are registered as, which does not necessarily line up. So you might be under your mother's last name in hospital, but you're your father's last name outside.
Thank you, Dr. Cartwright-Bastian. It was a great research project because I often feel like this age group of kids are the forgotten ones.
Yes.
Huh? We talk about all the less than 1-year-olds, and their causes of death are quite descriptively discussed. So I thank you for choosing this as your project. I want to ask you, in that 1 to 5 age group where you do have some international information, how did our causes of death line up with theirs?
So what I highlighted was that our cause of death that we got as primary was pneumonia and infectious causes, and that was comparable. They didn't have 1 to 5 or 1 to 4, they had under 5, so it still included a large proportion of the under 1, but the majority would still be 1 to 4 plus. So with that being considered, it was similar in that they had pneumonia as their common cause, and we got, for our 1 to 4 plus, pneumonia and infections as our common cause. My thought behind that was pretty much that we, in our setting here in the Bahamas, we have an awesome neonatology unit. So we more so now, for the 1 to 4-year-old, we've given them such awesome care to make it to 1. So then by the time they get 1 or over, then they experience the chronic illness. But the chronic illnesses, in terms of our documentation, which was one of the limitations that I found, aren't truly highlighted on the death certificates. So the way we fill them out, we have to learn, because we fill them out A, B, C, but A is why did you die, C is you were cerebral palsy. So it was difficult to extrapolate what was the true cause.
If I could make one further comment based on your recommendations, we have been looking at doing a childhood mortality review. Pathology has been pushing that for a long, long time, and we are going to try and see if we can get that going. And number 2, the PSAs, the Department of Pediatrics is trying to work very closely with PHA now in getting some of these preventable deaths and illnesses into the public eye. Thank you.
Thank you.
Thank you very much. Our next presentation is going to be by Dr. Deanna Bain, and her presentation is going to be on vasectomy concerns as a primary modality for reproductive health in New Providence, the Bahamas, a qualitative study.
Good afternoon. My topic is vasectomy concerns as a primary modality for reproductive health in New Providence, the Bahamas, a qualitative study. There's nothing to disclose, and the CME code will be given at the end of this presentation. I acknowledge God, my family, and my wonderful advisors who are also my co-authors. The Bahamas is a beautiful archipelago nation comprising over 700 islands and keys. In the 2010 census, it was noted that there had been a decline in the birth rate. I wondered, why was this? Was it that our family planning efforts were that dynamic? Were women primarily responsible? Were men involved? And if so, what role did they play? I eagerly embarked on a literature search using the following international websites and our local resources. At the Princess Margaret Hospital alone, I found astonishingly in the Department of Gynecology that 27 tubal ligations were performed in December 2015 alone, compared to 1 vasectomy in the past decade. Why was this? I said. I looked further. Glitch et al. In the World Survey of 1983 surveyed 99 million couples and stated that sterilization is the most widely used method of contraception in the world, and more women than men were using this procedure. Huda et al. In Ohio did a telephone survey of 719 persons. The men had fear of side effects of procedure. The side effects on their sexuality, their performance, the protection of the male genitals was something that was highlighted. Baroni et al., in their cross-sectional study of 180 practices over the United States of America, determined that the characteristics of men who would undertake this procedure would be white and educated, as compared to Hispanics and black who were from a lower socioeconomic and educational background. Kumar then embarked in their 2011 survey of the Indian men, the patriarchs and decision makers of the family, to find out if education affected their stance on vasectomy. It was concluded that although they had knowledge of the procedure, they were more inclined to discuss vasectomy as a permanent contraceptive method, and the cause was mainly financial. They got an incentive. Obito et al. In Nigeria, Africa, interviewed 150 couples in the family planning clinic. They stated that there is definitely a need to increase awareness and acceptance of vasectomy in the male family planning sector, as man's perception was that family planning is a woman's domain. Of course, in Africa, this is traditionally unaccepted because of cultural beliefs. I looked further, and there were no studies on vasectomy in the Bahamas, none in the English-speaking Caribbean, and surprisingly, WHO does not even list the word vasectomy as it relates to male family planning. Therefore, this is my rationale and justification for the topic. I aim to identify the concerns that may determine the knowledge, attitudes, and practices of men towards vasectomy. With this, I wanted to identify vasectomy-related concerns, assess these vasectomy-related knowledge, attitudes, and practices of men, and compare them between men who had a vasectomy and those who did not. I embarked on my quest to find a few good men in all 4 quadrants of New Providence, from the east at Elizabeth Estates Clinic, where my pilot study was done, to the west at Gambia Clinic, to the south at South Beach Clinic, and to the north at the Central Police Department. I incorporated all of the armed forces, all of the civic groups, all of the religious organizations, and any man who would talk to this girl and just tell me what is going on. This cross-sectional qualitative study took a purposive questioning approach. Therefore, I could not calculate a sample size. It was convenience sampling. When saturation was obtained, that was when I had no new thoughts or themes or ideas about the topic, my sample size was achieved. Men between the age of 18 to 85 who spoke English, understood English, resided in New Providence, who were married or unmarried, vasectomized or non-vasectomized were my inclusion criteria. Of course, those who did not fit that were excluded. Here's a sample of my self-formulated survey key. It's a 10-key open-ended question survey. Part A and Part B. Part A comprises of the demographics for the men. Part B has the open-ended question. And embedded in one of the open-ended question is one Likert scale yes-no question. The men were recruited and self-volunteered to participate in a confidential interview. These men opted to have a single in-depth interview or a focus group interview comprising of 5 to 10 men per group. Each interview was recorded and transcribed verbatim. Here's an example of what my transcription looked like. This is done in an Excel spreadsheet. On the left were the questionnaire questions, and on the right were the responses. Now, how do I get the words that they told me for you to understand in numbers? We are used to quantitative studies here. So I searched for a method. I found ANCONC 3.44 as a proper tool to use to take my transcriptions, transfer them into this program, and the most common words and themes arose. I deleted words such as I, but, and, I don't know, maybe, sometimes, all the empty fillers. And I grabbed the meat of the matter that the men were saying. First 25, then a second 25. I crossed to them, analyzed them, and then took the last 100 transcriptions and recoded them for a proper analysis. Out of these, themes emerged under which the questions fit for the responses of the men. And the results were listed beneath. Here's my word chart. The most common words are bold. Man, more, woman, children, vasectomy, license to sex, father, Bahamian, man, head, defender, protector, were the main words that came out of this study. What did I find? I found that 94% of Bahamian men used the health care facilities. 94% of the participants were Bahamians. There were less than 1% Jamaican, Chinese, and Haitian. There were more than 50% of the participants over the age of 50 years old, and less than 10% under the age of 25 years old. I also found a paternity number with an increase in the average number of children with increasing age. Men over the age of 55 had more children at an average of 6, and men less than 34 had an average of 1 child. I also discovered that 48% of the men had at least a high school education. 31% of them had a college education, and 21 had no high school level education, and they were subdivided according to the employment status that gave these answers. Limited knowledge of vasectomy and perceived traditional beliefs arose when I asked, what do you know about vasectomy? Over 80% said, I don't know. That's castration, doc. The biggest myth that arose at 35%, and body language was displayed in 100% of the cases. What does that mean? I don't know. I'd have to do a study on the body language of men. Protecting manhood and the male genitals. Do you know anyone who had a vasectomy, or would you have one? Doc, that's where the magic happens. Cut my what? Doc, eye for that. And the one Jamaican in the group said, why not touch my nuts? I said, okay, fair enough. Ego at 99% of the cases. Verbally protective, and only 1% said yes, I would consider. Financial, personal, and interpersonal relationship instability. Why do you think these men chose to have a vasectomy? The main thrust of this question came from a man who said, Doc, I tell my wife, she better get out of here. I sniffed 15 years ago, you better go find your baby daddy. Career goals was a concern. This would have held me back. Children are expensive, Doc. Finances took a 20% thrust in that question. Fear of the procedure and limited options for male family planning methods. So what are some barriers to vasectomy? I asked the men after thoroughly describing the procedure. Boy, Doc, let's stick with the norm. Let the woman take the pill or give us a pill. Cut my where? No, boy. What if I can't perform no more? Man, a man and his wife don't need no condoms. Fear of the procedure was 88%. Comfort with the present method was 97.8%. And of course, 0% chose abstinence. Restoring man to a leadership role in the family and partnership in the family planning came when we asked, what is the man's role to the children and the family? Broad-chestedly, more than 90% say, oh, we're the protector, the provider, the defender, the priest, the king, and the head. 10% discovered that we are the patriarchs. A real man protects his family and secures their future. So, it is estimated that we are at a pre-contemplation stage of change. With the given statistics found here locally in Princess Margaret Hospital, we have confirmed that Clutch is right. More women do prefer surgical sterilization. The characteristics were similar to that seen with Baroni et al. In age and average of children, but different in race, as we had no whites and no Latinos in this study. Fear of the procedure, loss of masculinity, sexual function, as well as protection of the genitals, mirrored that of Atkins and Jawitsky's 83 paper. Myth, uncertainty of the procedure, mirrored that found in Nigeria with Owapito. There is the need for further education and counseling programs to increase acceptance and to debunk the myths and misconceptions, Owapito concluded. Barriers to male involvement was similar to that in Kabaganye, in Uganda, but different because Ugandans prefer much larger families. Education played a minimal role in the service in Ohio. However, men still opted to have the procedure done. Here, they were educated and they said no. Younger men preferred the norm, letting the woman take the pill, getting tied off. Older men said, I prefer that we sit down and say how much children we're going to have. This is also seen in India. My data collection was halted briefly by Hurricane Matthew as my house was flooded. So I lost my initial data and had to start all over again. But space availability was a major concern in most of the clinics, as I needed a private room for the confidentiality to be maintained. I concluded then that the themes identified the men's concern about vasectomy. And of course, in Providence, it's a resounding no. Education, however, is the key to advancement of vasectomy in New Providence. I recommend that further studies be done in vasectomy and men's health. The impact of this study is a national one. This thrusts the avenue for family planning initiatives to be sparked in our country. And for the future, it's an expansion in the men's health clinic. These are my references, and I welcome any questions.
Thank you very much, Dr. Bain, for waking us all up and for that delightful presentation.
My name is Kevin Darling. I'm the head of the market head for business banking for the Northern Caribbean, based out of Nassau, which the Northern Caribbean for RBC is Turks and Caicos, Cayman, and Nassau and the Family Islands. So they've asked me to come here today and talk to you a little bit about what RBC is doing and some of the products and services that we have available for you. I don't really like coming up and doing a product talk. What I'm going to talk to you a little bit about is where banking's going, and as you have to deal with your business, deal with your personal banking. We're all very busy in today's world, so I'm going to talk a little bit about something called digital banking. So you've heard a lot in the papers around RBC and what we're doing in the marketplace and the types of changes that are coming. So I was sitting in the overflow room for a few minutes listening to the last two papers that were presented, and one of the things that struck me is that the papers they're research papers, they're trying to solve for X, whatever X happens to be, and much like that in business, we try and do the same things. So one of the things that we try and solve for through research and surveys and the same types of questionnaires and so on that I just heard about in the papers is, what do our clients want, where are they going, and what do they need next from us? And you're talking about an industry that has been around forever. Our history in Bahamas alone is 109 years. And one of the things that a lot of people don't realize is that we had a branch here in Bahamas long before we ever had a branch in Toronto, Canada. We were an East Coast bank in Canada. We did a lot of trade financing and so on on the East Coast in Canada, and we didn't expand into Central Canada until well after we were established here in the Caribbean. So today I want to share a little bit about digital banking and how that impacts our professionals and our private banking groups. I want to thank the organizers for involving RBC again. The professionals market, which you all fall into, is a priority market for RBC, not only here in the Caribbean, but also in Canada and the US. Change, like your industry, is coming to every other industry in the world. For us, it's digital. The days of cashing checks and making deposits are long gone for this next generation of millennials. They're looking for convenience, they're looking for accessibility, they're looking for creativity and how to get their banking done while they try and balance their busy lives. So for us, offering products and services that cater to that need is extremely important for our continued survival in our industry. Our mobile app, which I'll show you a little bit here on the screen in a minute, was recently launched and allows clients to conduct transactions without having to join a lineup in the bank. We know to keep pace, we have to be flexible, forward-looking in our approach. So we're doing the work today to set the foundation for future generations by using technology. The population of the Bahamas is about 395,000. There are 333 subscribers to the 333,000 subscribers to the internet in the Bahamas. That's 84% of our population has access to the internet. If you compare that to the balance of the Caribbean, which averages about 54%, we're a highly technological population. Within that population, about 230,000 people consistently use social media. So when we look at that, and we look at 84% of our population is online, over half our population is using social media for various things. You know, where do we need to be going forward? And where we need to be is in the spot they are. So we use a phrase internally sometimes is we have to be in the client's path. And if we're not in the client's path, we're forcing them to come to us, which historically has been our industry, where we push you to come into bank branches and so on, where now we're launching things in our digital channel like mobile banking, online banking, paying your bills, transferring, working capital for professionals where your operating facilities are there, and merchant services. So there's a number of businesses that, for all intents and purposes, can put enough procedures in place that they don't need to send somebody to the bank every day. And our goal is to build on this digital channel to expand those services. So we're running a pilot project right now that starts next week around doing wires from your phone. So we're piloting it internally with staff here in Bahamas starting, I think, the 7th, and we're hoping to roll that out to the general population sometime in November and December once we get the kinks out of it. You know, a lot of the large businesses we see today didn't exist 10 years ago. The Googles of the world. Facebook is another one. 15, 20 years ago, nobody would have thought of Facebook. It's now one of the largest corporations in the world. And as a result, we've got competitors coming into our space that we never had to deal with in the past. People like Google Pay, PayPal, Amazon. You know, the banking is not a complicated industry. We do three things. We store money for people, we lend money to people, and we move money for people. And that's the essence of our business. And the biggest part of our business is the movement of money, and now we have sort of non-traditional competitors entering that market as well. So for us, we have to be different types of bankers. You know, I was hired by RBC 40 years ago. I started as a bank teller 40 years ago in a branch in a small town in Canada. I've lived in 20 different communities since then in that 40 years, including Nassau. Prior to this, I was in Barbados and Eastern Caribbean for a few years. I remember the day that we introduced ATMs. And we thought, wow, that eliminates the need for branches. That was 40 years ago. And we still have bank branches. But we have bank branches in a different way than what we had in the past. And that's kind of what I'm talking to you about today, is the traditional bank branch that you've seen will evolve into something very different than what it has been or what our parents would have known. If you look online at what Bank of America did this year, they kind of reversed the normal evolution of banking, in that most of the banks internationally are shrinking their footprint, which means we're closing branches and we're amalgamating. Bank of America opened up 7 new branches earlier this year in the US, but there's not a single staff member. So you have 7 branches where you walk in and you sit in front of a computer screen and you chat with somebody in a call center. You do your loan applications from your phone. You do your mortgage applications from your phone. So this is the evolution. So I'm going to show you just a short video here. The sound isn't there, but I can talk to it. But this is what we've come out with is a world-class app for the Caribbean. It's rated 4.6, 4.7 in the Google store right now. It's very highly rated. Our peers in Canada want to get their hands on this because their app isn't quite as good. And we're telling them you can't have it yet because we haven't got it finished. And as we build it out, we will be transferring it up and letting the folks in Canada use it. But it'll give you a little bit of an overview of, if you haven't seen it, I guess you do hear a little bit of music, okay. So really it works on Apple and Android. And you can go look at it at our website if you like. It's the same thing that you would see on a computer screen. Very quick to download. And that's the actual screens you're seeing. If I opened up mine on my phone here, this is exactly what it looks like. So it talks about transferring money, paying bills, sending to another RBC client. We hope that by April next year, we're in a position here in the Bahamas that we can send interbank payments, which would be beneficial. So that just gives you, I'm not going to play the whole thing, that just gives you a basic idea. So then that's kind of where we're going on the digital side. So then when I look at, what do medical professionals need when they open their practice or when they grow their practice or they want to buy a practice, whatever the case may be. So we have specific programs developed for professionals. Now we do have some folks out in the front lobby there that can help you with some specific questions and so on, and I'm glad to take any questions you have when I'm done. But these professionals programs are really designed to deal with people in your line of work. And when I say that, your line of work typically is not manufacturing something. To a certain degree, it's a little bit the service industry, but it's not a traditional industry. It has a different cash flow to it. It has a different structure to it. It has some very heavy costs associated with equipment. And that equipment has to be turned over on a regular basis because you have to keep pace with technology. So when we look at our professionals package, it's built to grow with your practice or to grow with your center. We also have a student and interns program, and that's how we help students and interns get started while they're in school and provide some basic services for them to help them get a leg up on before they graduate. And then once you're established and you've got your practice up and running and you're starting to finally enjoy some of the fruits of all your schooling and all your labor, and you get into managing your own portfolio, we have our private banking division, and it is really designed for those professionals that don't have time to bank. This is really a concierge type service. It's very high-touch personal service, and they take really a wholesale look at your entire personal banking, holdcos, your business. They work with our business bankers and so on, and they take one look at it as opposed to, yes, we can do the car loan, or yes, we can do the mortgage. Really, it's a one-stop shop, and you can set up all of those things with that personal banker or that private banker, and that private banker stays with you as you continue to grow. And they spend a lot more time on advice around your future goals and things about, what do you want to achieve and how do you get there and how do we set a plan to get you there. And that's the advice portion of what we do. I mean, we can move money around, we can store money, we can lend money, but where the value add in that type of service comes is that advice portion, whether it has to do with, your future children going to school, or whether it has to do with, buying a second home, or those types of things. Really, they take a look at what those goals are and try and design a plan for you. So that's really, what I'm going to talk about as far as, what RBC has to offer. I'm more than glad to take any questions that you have, if there is any. And like I say, we will be out in the courtyard there. Yes? Do we have a...
Can we put our hands together? Everyone for Kevin Darling. He's the Senior Vice President of Business Banking from Royal Bank. And he's telling us how to plan our futures and how to get ahead. We really appreciate the talk. I'll probably come and speak to you afterwards.
Not a problem.
I'll be the first of the line, so wait your turn. Do we have any questions?
Thank you.
Because you spent some time in the Bahamas, you said, and you have a lot of historical facts and information, and I see some of that information that I can use, and also the information the students can use, and also those who are setting up their new practices, and I'm sure they will speak to you.
Thank you. Thank you. And that's something that if there is a group that are looking at setting up practices, let us know. The private banking team and my commercial team are more than happy to come and sit down with you at the end of the day or for breakfast or whatever works with your schedule to try and figure out how we help you attain those goals.
Good afternoon.
Good afternoon.
I noticed you mentioned about the online accounting and banking, but how is it protective against, I guess, like being hacked or cyber attacks? Like how do you?
Okay, that's a good question, and I spent a portion of my career, about 2 years, traveling, talking about fraud for the bank, because our clients are at risk, right? So what you're seeing today from an online banking or an app standpoint, from a security standpoint, can't be hacked unless you give somebody that password. So if you look at the bank's mainframe, and I'm not a techie guy, I've got grown kids that help me with that stuff. We have 7 firewalls on our mainframes. So a firewall is to prevent somebody to get in there and get hacked. We've only ever have somebody get past number 1 in our history, and he was stopped dead in his tracks. It doesn't mean we don't have people trying right now, because they are. So, you know, really from protecting your financial information really falls to you as the consumer. And it's not just your bank, your app, or your online banking. One of the biggest challenges that we have with fraud is that email that shows up in your inbox that you click on. So phishing is, and for those of you that don't know what phishing is, there's 2 types of phishing. There's phishing and then there's spear phishing. I grew up on a farm in Canada, and spear phishing is something that the local rangers don't like you to do. But so spear phishing is a very targeted attack. So they found you on Facebook or they found you on Instagram, and they see your lifestyle or whatever the case may be, and it's a very targeted attack. And they will come after you with a specific story that would fall in line with your lifestyle. Phishing is an email that there's when I was doing this talk years ago, it was called a 246. But they have these cafes in different places around the world that the economies aren't great, and they've got people in there just searching the internet for email addresses. And they'll send out 4,000 emails a day. And embedded in that email is one of 2 things. One is a virus that ends up in your computer that you don't know about, and then they access your passwords and so on, and that's how they get access. Second is they'll ask you for something. There is no financial institution in the world that will ever email you and ask you for your password, ever. So as far as protecting your banking information, it's really about yourself and protecting that password. That password's key. And, you know, as much as it's an irritant, I know in our organization I end up changing my password seems like it's every other week. But on your banking information, I would suggest that, you know, once or twice a year you do make that change. And then the last thing I would suggest you do is look at your bank account every day, right? If you leave stuff until something's happened, then it's too late. But look at your account every day. That's the key. But protect the password, protect access to your computers, those types of things. Don't answer emails you don't know who they're from. If you're ever in doubt and you get an email from your bank, send it to your banker. Because what we do is we have an internal security division, and we send those to, and they try and get them stopped. But if you're ever in doubt, pick up the phone and call your banker. Go into the branch and show them your phone. Whatever you need to do, but don't answer the email, and if at all possible, don't open it. Okay? Other questions? Yes.
Good afternoon. Thank you for your presentation. I just had a question in regards to the preferred banking, if that extends to other professionals. I'm a physiotherapist, and I know when I went in the bank maybe a few years back, I was told that was kind of like for accountants, doctors, lawyers, those kinds of persons, and it didn't extend to me. So I'm not sure if that has expanded or it's still that way.
You're 100% right. That's the way it was. Mm-hmm. No, you would be considered in our professionals program now. And that was one of the things is when the professionals program is not that old. It's less than 10 years old. And as we expand it, I mean, there's a lot of different specialties that you can expand it. So, you know, architects was another one that was never in there, that we've added architects and so on. So it is a wide, it's not restricted just to a GP, for example, right? Or it's not restricted just to an accountant or a lawyer. So I would suggest to you that if you get the answer no, you need to get that person to ask somebody else. Okay? Any other questions? Okay, well, we have folks out front. Like I say, if you want to have a little bit of one-on-one with them, they'll be more than glad to take your questions. But enjoy the rest of your day. It looks like it's very interesting. And thank you for this opportunity.
Okay, thank you once again, Mr. Darling, and we would see you again soon. And we looking forward to the support of Royal Bank for our future research days. Thank you very much.
Take care.